So the next presentation actually is interesting because it has a bit of a twist. Dr. Khalid Johani from King Khalid University Hospital, Saudi Arabia. King Saud, they gave me a wrong name. From King Saud University Hospital, Saudi Arabia.
Yes, assalamu alaikum everybody. So it's actually a bit complicated, Ahmed. It's King Saud University, King Khalid University Hospital, King Fahad Cardiac Center. So we have all the kings of the kingdoms.
Memorize that.
So
no way.
Yes, so thank you for inviting me. I know the theme of this talk is the calcium and IVUS. We want to switch gear a little bit away from calcium and to stress on the importance of intravascular imaging, that it doesn't only help you to optimize, as mentioned before, to make your PCI precision and maybe achieve near CABG result, and especially in multi-vessel CAD. If you want to compare our results to surgery, you have to really do it optimally with the use of intravascular imaging. At least that's what I believe in. And it should be IVUS in every cath pack for PCI. And hopefully we'll reach that stage in the future. So today's case is a 55 years old gentleman. He's only hypertensive, not compliant to his medication. He had CVA 5 years ago with no residual, or with residual weakness in the left side. He's a non-smoker with no other risk factors. He actually presented early on in the morning at 5:30 a.m. While asleep, he woke up with a severe retrosternal chest pain that was associated with mild shortness of breath. So hemodynamic was acceptable, and he had slight elevation of blood pressure on arrival to the emergency in 150 systolic. So the ECG was done at that time, showed inferior STEMI. We have a very strict KPI at our hospital, door to ECG time within 10 minutes, door to balloon time within 90 minutes, and it's been chased over and over, and it's very important to maintain that KPI, which is relevant in this case. So cath lab was activated immediately. I was actually in the parking going to the hospital for my usual cath day, and we activated the cath lab. This is the ECG actually post. This is a chest x-ray in the emergency, and that was his angiogram. I usually start with the left side, always, because I care about how the left main looks like before any intervention. As you can see, there is a normal coronaries with nothing significant there. And then this is the first shot of the RCA. I'll repeat it again in case you want to see how would you approach this case. It maybe sound like a straightforward inferior STEMI. It's actually not. So maybe, would you start by IVUS? Would you just, it's a STEMI, he's having pain, hypertensive, chest pain.
Pretty much straightforward inferior STEMI. Any thoughts on this?
Well, the left system looks normal. The RCA looks clear proximally, and it looks like a SCAD to me, a dissection. Of course, what you want to do, first of all, he still has ST elevation, which means ischemia.
Yes.
Some people argue conservative treatment might be okay, but the fact he still has ST elevation and chest pain means you need to do something. Important to make sure you don't lose flow, i.e. so you have to be careful to wire this artery in the true lumen, which might be difficult, but with careful approach, you should be able to do it. And then you could do imaging, and then I probably would try avoid putting a stent if I can. We just prolonged balloon inflation might be enough to establish T3 flow, resolve the ST elevation, and get the patient much better because the SCAD or the dissection will resolve.
Yeah.
Gabriel, choice of wire?
I do agree with one. Of course, you know that in this case, my wire should always be SWOT 03 guide wires. We publish our experience, and we collected more than 75 successful cases of wiring dissected vessels. So SWOT 03 wire, the softest as possible.
So a soft, non-hydrophilic, non-polymer jacketed wire is what you really want to avoid extending that dissection plane.
Yeah, so because the patients clinically was actually restless, in pain, hemodynamically unstable. We didn't have that luxury of time of scratching our head, especially at 7 o'clock in the morning without the morning coffee. So we proceeded directly with the use of 4-course wire. It passed easily without any difficulties. and we proceeded with ballooning of that segment and followed by stenting. And this is what was shown. The patient was restless, hypotensive, nitro. I like to give nitro even if the patient is hypotensive, especially in a situation where I think spasm is a key. Followed by another round of stenting distally, and here where the patient started to cool down a little bit. So his blood pressure picked up a little bit. He's not in pain, probably also the effect of some of the narcotics. And that was the angiogram where I decided, yes, bring the IVUS, I have time, I want to interrogate that, especially the proximal segment that didn't look benign to me.
Can I just make a comment? Sorry, I've got the... this is it's quite excellent teaching for this, because you've got a subintimal hematoma right now that's being trapped by the distal edge of the stent and just spates down proximally and distally. One way to treat this to avoid putting more stent using a cutting balloon that will open that area where the blood is trapped behind the intima, and that you wouldn't need any more stents. But that's what typically could happen.
Excellent comment, Mohamed. And if you're in doubt, intravascular imaging would indeed tell you, is this a dissection flap or is it a submural hematoma, subintimal hematoma that can be indeed relieved with a cutting balloon?
Yeah, so I IVUSed the case, and I really like this actually version of IVUS from the Boston Scientific, where you can see clearly the delineation of all the 3 layers of the vessel wall. And it actually gives you a near OCT images with the high definition 60 megahertz catheter. It's a long clip, but I'll go where the money is. And this was after the first stent. You can see the stent here is opposed, and you can see now from 12 o'clock to 6 o'clock a very large hematoma, but yet the impressive image is not yet is to be seen. Where you can see here that the wire luckily is intraluminar with invagination of the lumen by a very large, very huge. This is actually by far the largest I've ever seen. We have a lot of senior operator here. I don't know if they have seen similar cases where there is complete detachment of the adventitia and the vessel wall is actually floating in a very large hematoma. Here, I thought that it's not really only a SCAD, there is something going on. But the patient actually went, again, hypotensive with chest pain, restless, the whole cycle of epinephrine. So I really decided to stent, stabilize, and then deal with this patient afterwards. So we did a very long stent up to the ostium. Then both dilated after that IVUS, saw some area of under expansion. And that was my final results. The patient did cool off, no chest pain. ST segment went down as in the first ECG, and we took him off the table, but we had a very bad thinking that what could be the diagnosis of this patient, especially if you remember, I'll go back quickly into the left-sided injection, where actually when I showed it to some of the colleagues, they said there is something weird and funky about this catheter in the left side. It dances in a very funny way. If you can notice here. So we took the patient back to the recovery area. That was the virus run, which showed the well-opposed stent up to the net. His oxygen requirement increasing with mild chest pain, and he's becoming more shocky. So we asked for a stat echo because we thought of the very lethal diagnosis of aortic dissection that was missed in this case, and PCI was done in a very high mortality case. And lo and behold, you can see that there is a flap in the aorta with a very wide open AI in this case. He became, and indeed he did have some sort of aortopathy where the aortic size was 47. He had a severe AR. He had regional wall motion abnormality with depressed LV function. So he was shifted directly to the CCU. Cardiac surgeon were called, and CT scan was arranged quickly for the patient. And as you can see, that this is an extensive aortic dissection extending from the root down to his iliac. Going from the radial, I think, was the standard, and by luck, we didn't go through the false lumen, which many cases where you can't intubate the coronaries because of being in the false lumen. But in this case, we were maybe too lucky. We missed the diagnosis of aortic dissection. So he went to the CCU. There was a delay of logistics up to 4 hours. The patient spiraled down to be shocky with organ damage, and they took him to the OR, and when they tried to sew everything, nothing could attach, as per the surgeon mouth, that his tissue was very friable, and he was declared dead in the OR table after a long, long surgery. The take-home messages that I learned personally, and I want to spread, that maintaining a good KPI is important, but shouldn't let you skip. Because I think if we did an echo bedside while shifting the patient, maybe we could have seen that AI. If we did focus on bilateral blood pressure, maybe that would help. I know this is rare, fatal, but it could have maybe saved the patient. Intracoronary imaging, it's helpful, yes, in calcium and how to optimize our results, but it can help you in diagnosis, where in this case really made the suspicion of aortic dissection extending into the RCA as a diagnosis. And as always, reassess the patient subjectively and objectively as the patient gets out of the cath lab. Thank you so much. I'm on time.
I think we have time for a couple of reflections or questions. Thank you, Khalid. Excellent presentation. Dr. Colombo. So what's your take-home message from this case? How would you have?
I don't think anything different would have made a difference. Maybe the only difference, you could have saved a couple of stents. But, these things tell you that sometimes the problem is not where you see it at the beginning. It's outside the frame. But the tissue were friable, and even if the surgeon would take the patient to surgery immediately, I doubt would have made a difference.
Can I just ask, sorry, what's KPI? I couldn't get, what's
Key performance indicators.
Key performance index.
Key performance indicators.
Also, the second thing, it is quite unusual to see that the mid-RCA, that the one that showed the stenosis, when you have a dissection in the aorta extending to the RCA, usually it's the ostium starts proximal and continues.
And
This is something really very unusual.
I'll tell you, it wasn't a difficult intubation of the RCA. It was a straightforward with a JR first time, no difficulty at all. But it was indeed, as we can see from the CT scan, extending from the ostium, ascending aortic root into
No doubt. It just usually see the ostium, the proximal part blocked or causing the problem, then distally. But this is only in the mid-RCA, which is very interesting. And that's what probably threw everyone away. Otherwise, you would have probably thought of the diagnosis.
I think the proximal RCA is very big, and you already had an hematoma, but it wasn't compromising the lumen.
No, it wasn't. And
Essentially, there is no way on earth he could pick it up. We have one brief comment here and one brief comment from Carlo, and then we end the session. They're shouting for time. Go ahead.
Just to add up to the dilemma, I think your comment here that the proximal part of the RCA was normal when you started, at least angiographically how it looked, okay, and the lesion is actually in the mid to the distal third, then chances are when we developed the hematoma broke backwards all the way up to the ostium. When we put the stent, we made it worse because we allowed the hematoma to evacuate into the aorta. And in order to do that, the only way in order to do that is to cause a dissection. So I could be, although I agree with you, the movement of the guide catheter was very suspicious in that there may be a significant AI to start with, but this is also a likely scenario.
Actually, in retroscope, it's always easy, but you can see that the distal RCA was large compared to the ostium. Which at that time we didn't see it, but after we said, yeah, there is a huge discrepancy. So there was a hematoma from the beginning, and confirmed by the CT scan.
One thing that we lost is to do V-grams in acute patients. When I was a fellow, before doing coronary angiogram, we always did a V-gram. So if you did, when you have a strange case, something is a little bit different, to do a V-gram you would have seen a ventriculogram, a left ventriculogram, you would have seen from the aorta. I mean, nowadays I see people are so afraid to inject contrast.
Yeah.
They believe that it's toxic. It's toxic only
It
if
is poison.
Only if creatinine is high.
Yeah, it
but contrast is not toxic.
But maintaining a KPI, sometimes LV gram delay that.
It is
Yes, I
becoming
agree
an
with
option.
that.
It is becoming a forgotten practice indeed. Khalid, one brief comment.
Well, first of all, I don't see you need the LV gram. You just do an echo while you are running the patient to the cath. You are wheeling the patient to the cath lab, and you will see it anyway. And you don't do the creatinine, so that's why I don't think it's safe to do LV gram right and left without having this essential information. But I mean, I was commenting the point. In retrospect, is not a human, not a young woman. They doesn't have that mid-distal occlusion that you often see, and multiple dissection that you often see in these ladies. There was something odd, and looking at that IVUS, I also agree, I've never seen such an enormous dissection running around with a small lumen completely detached from the adventitia. So it was a difficult diagnosis. I don't think the fact that you spent some time fixing the artery really made that much of the difference.
It was clinically because he was hypotensive and in extreme chest pain. At
If
that.
Carlo hasn't seen it before, then it's very rare, I assure you. One last comment.
Khalid, my teacher at the Ottawa Heart Institute long time ago, he was a great clinician. And he taught me one thing. He said, when you're being called to the ER for a patient with chest pain, tell yourself, I'm not going to miss a dissection today.
Yes.
Go and feel both pulses and go and listen to the carotids and sit the patient and look for AR. He taught me that, and I've done that since that day. And thanks God, I haven't missed a dissection since that day, because he actually taught me this. And I think I taught you this, by the way, but that's fine.
Thank you very much, Khalid. Excellent presentation.
Thank
It
you.
provoked a lot of discussions, but we really have to end it. Excellent presentation, excellent comments.